So having selected the patient, let's go over just very briefly some of the procedures. I'm sure many in the room are familiar with the procedure of cervical conization, and it is it's exactly what everyone in this room will probably do, which is to make sure that you obtain adequate margins. And if the margin is close or positive, I will be addressing that in some of the future slides. With a simple cervical conization, you are able to achieve cure for patients with stage 1A1 disease. When the patient begins to have stage 1A2 disease, one consideration is trachelectomy. And there are different types of trachelectomy, as you know. There's a simple trachelectomy. I think I skipped some slides. I'm just going to go back again, looking for this slide. Different types of trachelectomy. This here is an example of a simple trachelectomy when you actually remove the entire cervix. In this case, a patient with carcinoma, microinvasive carcinoma of the cervix, as you can see in the histology. So how do you perform this procedure? It's really similar, almost similar to your approach at performing a vaginal hysterectomy or a Manchester Fothergill operation. So basically, you start out by injecting vasopressin, make an incision around the cervix, and try and dissect off the bladder as much as possible, anteriorly, the rectum posteriorly, and then here is clamping of the cardinal ligament on each side. And once you do that, you are actually able now to isolate the cervix so that you can safely make your incision and amputate the cervix. Closure of this requires placement of hemostatic sutures all around, as well as overlaying the exposed cervical tissue with vaginal mucosa, as well as placing a prophylactic cervical cerclage. So this is what one will do in a simple trachelectomy. But once the disease is beginning to extend beyond just stage 1A1, 1A2 disease, up to stage 1B1 disease, one will offer the patient a radical trachelectomy. The difference between the simple trachelectomy and radical is shown here, where now you're now taking some parametrium, you're taking the entire cervix and the upper vagina as well. Trachelectomy could be done abdominally or vaginally. And as you know, there are advantages of abdominal versus vaginal trachelectomy. And this is well summarized in a fairly recent paper by Rob et al. In Lancet Oncology, where they reviewed abdominal versus vaginal trachelectomies. As you can see, the main point from here is that both procedures are highly comparable in terms of the oncologic outcome. In terms of the obstetric outcomes as well, both procedures are comparable, where you have up to 32 conceptions out of 175 planned pregnancies. In the abdominal group, you have 300 conceptions in the vaginal group, and in both groups, patients are able to deliver, although it's recommended that delivery be undertaken by cesarean section. So let me just review a few of the oncologic outcomes in more detail. This is another study from Berlin, where 320 patients underwent vaginal trachelectomy. 10 of those patients had relapse within a follow-up time of between 6 months and 10 years, and there were really no significant patient-related characteristics in this particular study, but as I will show you, Patients who have disease greater than 2 centimeters in size, as well as extensive lymphovascular space invasion, tend to be more affected by recurrence. Here is another study by the group from Quebec, where 140 patients were offered vaginal radical trachelectomy. Their recurrence rate is approximately 5%. And as I earlier mentioned, the most important parameter that is associated with risk of recurrence is the size of the primary tumor when it's greater than 2 centimeters. I would like to point out that in all of these studies, patients having the vaginal radical trachelectomy usually undergo preliminary laparoscopic lymph node dissection, lymphadenectomy, and those lymph nodes are sent for frozen section. If they are positive, the procedure is abandoned. So with that said, what are some of the newer treatment options? So we've already heard about neoadjuvant chemotherapy, and it can actually be applied in this setting especially. Again, the patients undergo laparoscopic lymph node dissection. Here is a study whereby 7 patients with bulky 1B, that is up to 4 centimeters, and 2A1 tumors were given neoadjuvant chemotherapy consisting of Taxol, ifosfamide, and platinum. And some of the patients then went on, all of the patients then went on to have their vaginal radical trachelectomy after evaluation of the lymph nodes. In this study, there was optimal response in 4 of the 7 patients. Here's another example where patients received TIP or gemcitabine and cisplatin. These 7 patients had no recurrences. There were 4 pregnancies and 3 deliveries. Another example of 28 patients, 1B tumors greater than 2 centimeters. These patients had neoadjuvant chemotherapy. They had their laparoscopic lymph node dissection. In this population of patients, there was a 50% pregnancy rate, and 80% of those patients who became pregnant subsequently went on to deliver. So neoadjuvant chemotherapy followed by radical vaginal trachelectomy is a potential treatment modality in this group of patients.